So thank you, Runcie, and the rest of the Overcomers for letting me speak on this topic that's near and dear to my heart. Something tells me, though, that for a lot of you, if you are a member of this group, you've already had your surgery for ovarian cancer. So some of this may not pertain to you, but this is what we got going on right now. Obviously, the landscape of ovarian cancer has really changed with the medical progress, the new drugs like PARP inhibitors, and I'm not going to speak at all on that. I'm just going to speak about what's in my wheelhouse, which is surgery. And I do want to just say, well, here's are my disclosures. I do want to say at the end, I do have a video that we presented at the SGO meeting just recently, and there are pictures of organs in the belly. So if you're squeamish about that, please either turn off your computer, turn the other way, or close your eyes or whatever, because I really don't want to make people, as my children would say, grossed out. But I do think it's kind of neat the technology that we're getting ourselves into these days. So anyway, speaking about surgery for ovarian cancer, the topics that I'm going to talk about are primary cytoreduction and what's called secondary cytoreduction. Interval cytoreduction also in the sense that if we don't do surgery first and try to get all the cancer out, sometimes we give chemotherapy, or a lot of times actually nowadays, and then do surgery and then do more chemotherapy. Second look surgery is something that we're doing on trials now. It was out of favor for a while, but I'm not going to speak anything. I'm not going to talk about that at all. And just, I don't have that much time. So I'm just going to talk about primary and interval cytoreduction and what's called secondary cytoreduction or secondary debulking. So the whole idea of cytoreduction is also known as tumor debulking. It's effective in ovarian cancer if we can get almost all the visible cancer out or all the visible cancer out only because we have effective chemotherapy, which other speakers have spoken about. Patients who succumb to their disease eventually do develop chemo resistance. If they didn't develop chemo resistance, then we keep on giving them chemo and they would do great. But the idea, though, is that the larger the number of cancer cells that are present when you start chemotherapy, it's kind of like if the antibiotics. If you don't start antibiotics, you may not be growing resistance, but once you start the drug, then you have a higher likelihood of developing mutations, and those mutations can lead to chemo resistance. If you remember, like Darwinian survival of the fittest. But something that we talk about all the time is, first do no harm, primum nos nocere. And the shortest survival is an intraoperative death, but in second place is a perioperative death. So we have to make sure that we do these surgeries, get patients recovered in a timely fashion, and usually within a month of surgery, get people on chemotherapy. It's different for, let's say, pancreas cancer, where a Whipple procedure is done and there's no chemotherapy afterwards, so you have plenty of time to recover. For us, we walk a tightrope when we do these big operations because we have to do the cancer surgery, get all the cancer out, have people recovered and back and ready to get chemotherapy. So that background is because that there have been multiple prospective randomized trials that have compared the time-honored approach of doing the surgery first and then chemo to chemo and then surgery and more chemo, like a sandwich of chemotherapy, surgery, chemo. And the problem with these studies is if you look at the two first studies, they were called non-inferior, trying to say that, well, if you give the chemotherapy first approach, we know the surgery will be less extensive. And if you get all the cancer out, then why not do the chemotherapy first? Well, if you look in the first two trials, one was from England and the other was from Ireland. And I'm sorry, not England, Europe. That's the EORTC trial. And it showed that less than 20% of the time when you did the surgery first approach, that you got the result that you were trying to get, which is get all the chemotherapy, get all the surgery out before chemotherapy. So 17% in the Chorus trial, the Irish trial, and the 18% in the European trial. There are other two randomized trials to try to show that either neoadjuvant chemotherapy or chemotherapy first was non-inferior. Inferior, also a superiority trial in Italy called the Scorpion trial. And again, in the Japanese study, only 12% of patients got full surgery. And in the Scorpion trial, where they just did this trial for patients who had extensive disease, less than half of the time did they get all the cancer out. But remember what I said about the shortest survival is a perioperative death. 8% of their patients in this arm, there weren't a lot, there's only 84 patients, but 8% died in the perioperative period. And that's not something that we'd want any study or any center to have. And then so just, I'm sure a lot of you, because you are very knowledgeable about cancer trials and everything, understand more what I'm saying if I relate this to a chemotherapy trial. So when you're comparing surgery, which could be more extensive, and then chemo versus chemo and less surgery and things like that, it's like as if we were comparing drugs A and B to drug B, because the interval cytoreduction that was done was just a hysterectomy and things, not a big surgery. And let's say your endpoints were overall survival and progression-free survival toxicity. In the A and the B arm, only 12 to 18% of patients received a full dose of drug A. 25 to 34% received some drug A, but 58 to 65% of patients received no drug A at all. So are we really testing drug A here if they didn't even get it? So that's similar to doing surgery and not getting all the cancer out. There's no study that has ever shown that exposing a patient's abdomen to air is going to shrink cancer. So if you're trying to do surgery, you have to have some quality control and actually do the surgery you're supposed to be doing. But let's say we did have this trial go all the way out. What would we expect the results to be? Well, there wouldn't be any difference in progression-free overall survival because you didn't really give patients drug A. And would there be less toxicity with drug B alone? Sure, because a lot of patients did get drug A, but they got all the toxicity, but none of the benefits. So is this really a valid approach of assessing the efficacy of drug A? Or more importantly, for our situation, the progression-free and overall survival benefit of doing what's called surgical cytoreduction in the upfront setting or primary debulking? And the reason why I give that background is because what month did we in? March. I think in the end of May or June, these two investigators from Essen, Germany, Andreas Dubois on the left, and God, I'm blanking on his name. On Philip Harder, who work in Essen, they were the ones that were really behind doing what's called the TRUST study, the trial of radical upfront surgical therapy in advanced ovarian cancer. And we're going to see those results presented at the ASCO meeting in May. The results are pro-surgery, and they are important because in those other trials, when you saw that only 12 to 18% of patients got drug A, got legitimate surgery, in this trial, to be a center that enrolled patients, and we're the only center in America that was enrolling patients in this trial, you had to show that at least 50% of the time you got drug A. You got a primary debulking surgery where we got out over 50, we got out all the cancer and 50% of the time in our experience prior to this surgery, prior to this trial, I mean. So we're anxiously awaiting those results. I think it's going to show a lot of things that we were thinking was going to show. It may not be the home run that we want it to be, or may be, but we'll just wait and see what those results are. So that's going to be being presented at ASCO, hopefully in May. And this is just a comparison. There's a Chinese trial called the Sunny trial. And basically, it's the same kind of thing, advanced ovarian cancer. Should we do surgery first or give chemotherapy first? And it's mostly going to be in Asia, whereas the TRUST trial was mostly Europe, except for our center. So what happens when patients develop recurrent disease? They've had their primary debulking or neoadjuvant chemotherapy interval debulking, and they go a few months or a few years, and then unfortunately the CA-125 in CAT scan shows recurrence. So this happens all too frequently, as you know. If you take all the advanced ovarian cancer patients, greater than 50% or majority will eventually develop recurrent disease. And debulking surgery is, as you just saw, is a key element, whether it be after chemo or before chemo in the primary management. But is it something that should be pursued in patients who develop recurrent disease? So our institution and others reported multiple retrospective studies where we said, yeah, we think there is a benefit. But recently, a lot of prospective studies have been published. These are the three big ones: GOG 213, the American trial; Desktop 3, which was done by the same AGO German group. They're like the GOG of Germany. And the SOC1 trial was from China. And this was recently published in the last 12 months. And the bottom line was that they're both very, I won't go into the details of everything about each trial, but the bottom line was in the American GOG trial, they showed no difference in progression-free overall survival. They basically said, yeah, maybe you shouldn't do that. The German trial was a little bit more strict in not just who was entered in the trial, but what centers were allowed to enter patients in the trial. And the German desktop 3 showed both an improved progression-free and overall survival. The SOC1 Chinese trial showed an impression in progression-free survival, but not overall survival. So three different conclusions, but actually, in my opinion, understanding this, I think all three are very, very valuable, and they actually tell us a lot about who we should and shouldn't do a second operation for debulking on. But what were the similar conclusions? About 70%, 75% of patients got drug A, if you will. They got all the cancer out. And there was an improvement in progression-free survival if you got all the cancer out. But there was no difference in PFS or OS if you didn't get all the cancer out. So I think we can conclude from all these, if you're going to operate, you got to get all the cancer out. This idea that we took everything out, but we left a few little nodules here or there, that's not going to cut it. I didn't mean that as a pun, but so looking at the trial, the American GOG trial that showed no benefit to progression-free and overall survival, let's go a little bit, just a tad deep into why is that one the one that was so negative? Well, there's a few issues. Number one, in the GOG trial, the American trial, you could have chemotherapy, and then you could just later on, as a patient, if the cancer came back, the trial never said you couldn't do this, you can't do that, and they never kept track of those patients who went on the trial, got chemotherapy only, and then later said to their doctor, oh man, my cancer came back, you got to operate, come on, please, please, please. And we know that that happens quite often, that once patients are done with the specific aspects of a trial, they may dictate what they want to do. In the Chinese SOC1 trial, 35% of those who were assigned to chemotherapy later crossed over and had surgery. That's, in my opinion, very significant. The number 2 and 3 issues with GOG 213 was there is no selection qualifications for the centers nor the surgeons. So you could just say, we do the surgery maybe once a year, and you can understand that if you do one of these debulkings once a year, how good are your results going to be compared to places that do it every week? And there was also no specific patient selection criteria, which I'll show you is, I think, a very, very big issue. So in this American GOG 213 trial, there was an improvement in the time to recurrence. It was 22 months if you had surgery compared to 16 months if you just had chemo. But then somewhere along the line, the lines kind of crisscrossed, and the overall survival was actually went from worse to better when you got chemotherapy alone. So was there crossover here? We don't really know, but one would suspect something was going on. And so I think that was very, very well addressed in this Chinese study that just got published last year in Nature Medicine. And these slides are used with permission of the lead author, Dr. Zhang. So this was exactly what we're just talking about. Somebody has their initial treatment, they go into a remission, and they're 6 months later, the cancer comes back, so they're quote unquote platinum sensitive. And so is there a benefit to doing a second surgery, or should you just go on chemotherapy? Of course, when you do the second surgery, it's in addition to chemo, it's not instead of. And this was the initial just intent to treat, meaning, so what happened? Whether they crossed over, didn't cross over, whether they actually even got surgery, they were assigned, what happened? And there was an improvement in the median overall survival, but there wasn't any improvement in the progression-free survival. And here is the overall survival. So the p-value was 0.11 months. Let me just get rid of this. So there was it looked like there was a difference in the overall survival of 6 months in surgery versus the chemotherapy alone arm, but it didn't reach statistical significance. But part of the analysis, when they did what's called a pre-specified sensitivity analysis of adjustment by crossover. So when they took out the 35% of patients who crossed over, they did find, and this was something that they said they were going to do from the beginning, because this is kind of like real world data. They did find statistical significance in the fact that if you had surgery, you had a 24% decreased risk of dying of your disease within the study time. So it was significant that surgery was of benefit. And again, it's kind of okay if you say you're going to do this ahead of time. Obviously, you can imagine if you do a trial and then you start changing the rules and moving the goalposts, it's not as legitimate. So what they did in this analysis here is they took out all the patients. There was like 5 or 6 centers, all the patients in the center that crossed over, and they just deleted both arms of the trial. And they found a significant difference in the other centers where there wasn't as much crossover. They found a statistically significant difference of 21 months of improved overall survival if you did the surgery first, and a decreased risk of dying of 35%. So they concluded that among patients with platinum-sensitive recurrent ovarian cancer, surgery didn't initially improve overall survival if you just looked at the intent to treat analysis. But surgery provided a 21-month benefit of overall survival over control when you excluded the center with that high rate of crossover. Surgery provided an obvious high proportion of long-term survivors than chemotherapy alone. So really, really long-term, more than the medians of 13 to 3%. And also, when they looked at patients in subset analysis of patients who relapsed with less than 20 sites, the hazard ratio was 0.69, meaning a 31% in survival for surgery compared to chemotherapy alone. So, and I agree with their conclusion here that this is arguably it does support the efficacy of surgery in specialized centers and selected patients. Going back to the GOG trial on number 2 and 3, this is just a list of all the centers, 49 different centers that enrolled patients in GOG 213, 2 cooperative groups, 1 in America, 1 in Korea, but there were 0 qualifications for the surgeons or the centers. They didn't say you have to do 50 debulkings a year, 5 secondary cytoreductions a year. They didn't. And frankly speaking, 2 of the biggest centers that have written papers and really focus on doing primary and secondary cytoreduction, our center in the Mayo Clinic, we enrolled 0 patients in this trial. And number 3, the American GOG trial didn't have any eligibility criteria to enroll people in this trial for various reasons. They just said you got to get all the cancer out. So it didn't matter if you had disease in like 1,000 places. It didn't matter if your progression-free interval was just barely 6 months. It didn't really matter. And I'm not saying that's a bad thing when you're trying to do a trial. You just want to make sure that you have good eligibility criteria and that the arms are balanced. So I do believe, I'm not criticizing this other than to say that it has its role, and I'll tell you my thoughts on that in a second. So in our published paper from 2003, I believe it was, we felt that not everybody should undergo secondary cytoreduction. If you had one-sided disease and you're platinum sensitive, then maybe. But if you had carcinomatosis all over the place and your cancer came back very, very quickly, which unfortunately happens a lot, we would not recommend a secondary cytoreduction, a secondary debulking. And we've actually looked at this, looked at our model and compared it to the ones that are used, like the ones that they used in the AGO German study, and also the one in the Chinese study called the I model. And we wanted just to compare the results of using our selection criteria for surgery compared to their selection criteria. Not to prove that they're better or worse, but just to see where we stand. And so in the patients that we operated on using our criteria, only 49% would have fulfilled the criteria of the AGO. So in other words, we operated on 51%. 51% of the patients we operated on wouldn't have qualified for a secondary cytoreduction. Our model was kind of used to help develop the I model, so it's no surprise that they're both very, very similar. And if patients were not going to be operated on in the based on the AGO criteria, we still got all the cancer out 86% of the time. And so with very, very favorable survival results of a median progression-free survival of 21 months compared to the GOG negative trial of 18 months and median overall survival of 82 months compared to the GOG 53 months, we think these results compare very favorable. And again, feel that if you use selection criteria in selected centers, there is a benefit to doing a secondary debulking. So one last thing, and this is the video that I'm talking about. So if you get a little squeamish about seeing things in the belly, you may want to turn off your show right now. But this is something that we presented at the March 2025 SGO meeting on holographic imaging with virtual headsets for ovarian cancer surgical site reduction. And this doesn't necessarily mean that you have to do this at primary or secondary, but in a meeting like this, just to show you that, we're not just sitting there writing papers, we're still trying to improve our technical ability to predict good results with surgery.
3D holographic imaging with virtual headsets for ovarian cancer cytoreduction surgical planning. As a majority of patients with high-grade serous ovarian cancer are diagnosed with advanced stage disease, comprehensive surgery remains integral in the management of our patients. Improving preoperative surgical planning is essential for ensuring better patient outcomes and minimizing the risk of futile laparotomies. A 2024 study utilizing 3D technology on monitors and printing constructs for 60 patients with ovarian cancer undergoing cytoreductive surgery has shown benefit with duration of surgery, blood loss, hospital stay, and return of bowel function compared to traditional 2D CT imaging. They demonstrated that 3D technology has value in the surgical planning of advanced ovarian cancer, enhancing surgical precision and reducing intraoperative risks, which may aid in improving postoperative recovery. We hope to go even further with 3D technology with a novel implementation of new 3D holographic technology with augmented reality headsets, as this has not yet been studied in the setting of ovarian cancer surgical planning. For this feasibility study, we first obtained routine CT imaging for patients with suspected advanced ovarian cancer. We then utilized software to convert the CT imaging to 3D augmentation to be used by virtual headsets. The gynecologic oncology surgeons used the virtual headsets during the pre-operative planning time and completed a survey to predict which organs would be involved by disease. Following each patient's surgery, we then compared which tissues were confirmed and performed a statistical analysis to compare the agreement with the pre-operative predictions. Demonstrated here is a comprehensive view of one of the patient's 3D holographic renderings from the lens of the virtual headset. This is an additional mode to view the 3D augmentation engineered from a patient's CT imaging. Shown here is a demonstration of utilizing the 3D augmentation to visualize tumor involving the splenic hilum. The software was able to engineer tissue segmentation to isolate the spleen, shown in yellow, as well as tumor implants highlighted in green. We are also able to utilize segmentation technology to visualize the spleen without surrounding organs. This is the intraoperative video of the same patient undergoing a splenectomy with tumor implants on the spleen, precisely where the 3D augmentation demonstrated. The use of 3D augmentation also worked incredibly well to evaluate involvement of the diaphragm. The pointer tool here is indicating areas of disease along the left and right diaphragms. It appears topographically, which is difficult to visualize on 2D imaging. Here is the same patient with bilateral diaphragm involvement accurately depicted from the 3D augmentation. The use of 3D augmentation was also found to be useful for enlarged lymph nodes. The pointer tool here is demonstrating an enlarged left para-aortic lymph node chain.
Yeah, you don't need to. They, that's totally fine. But I really would like you to have the biopsy.
Here are the intraoperative findings of the enlarged left para-aortic node as demonstrated previously on the 3D augmentation.
Okay. I just want to it's not a straightforward one-side biopsy.
This graph represents disease involvement comparing pre-operative predictions from 3D headset utilization, which is demonstrated in orange, versus surgical findings confirmed on final pathology, as demonstrated in blue. At this time, the technology has been utilized for 7 patients with advanced ovarian cancer with more actively underway. The concordance rates are separated by organ system beginning with the ovaries, a small bowel mesentery and serosa, liver, spleen, and gallbladder, posterior cul-de-sac requiring a low anterior resection, bilateral diaphragms, para-aortic lymph nodes, and omental nodules. In conclusion, the novel use of 3D holographs from CT imaging with virtual headset technology is a feasible strategy for ovarian cancer preoperative surgical planning. Our experience demonstrated a high concordance rate for identifying disease in the pelvis, liver, gallbladder, spleen, bilateral diaphragms, omental caking, and para-aortic lymph nodes. More patients are needed to validate this technology in the setting of advanced ovarian cancer surgery. Future directions are underway, including the preoperative triage of neoadjuvant chemotherapy versus primary cytoreduction, as well as intraoperative use with artificial intelligence to determine tumor versus normal tissue, and evaluating perioperative outcomes. This concludes our video. Thank you.
So the the narrator there was AI generated, so it kind of went along with the theme of you know, using technology to improve things. So in conclusion, surgery has many roles, as you've seen in the management of patients with ovarian cancer. Multiple phase 3 trials have recently been done and will be reported in the near future, better outlining the best settings and criteria for surgery, whether it be primary or secondary. The TRUST trial will soon be presented at ASCO, hopefully, and answering the question of whether or not there is a benefit to doing the surgery first, which requires oftentimes long operations, or neoadjuvant chemotherapy, whether they should be done in expert centers and what are the criteria to use. The Desktop 3 German trial showed that there is a benefit to doing a second debulking in carefully selected patients in expert centers. But GOG 213, which was a negative trial, did have a lot of benefit because it showed that you can't just willy-nilly decide to operate on somebody anywhere. They should be seen in an expert center that does a lot of these procedures. And even in the expert centers, we just don't operate on everybody. We have to use very good selection criteria. The SOC1 Chinese trial, in my opinion, showed that, well, if you missed it and you didn't get a surgery right at the first time of recurrence, the trials don't say, well, can you then do your second operation after you've already started chemo for your recurrent disease? And I think you can. And that's what the benefit of the crossover was. And studies are ongoing to continually try to improve all these things, our patient selections, decrease our surgical complications, maximize cure and long-term survival, and make everybody an overcomer. So thank you to Runcie and all of you for taking the time to listen